गुड इवनिंग सर। सर आपका सर डॉक्टर तनीष के नाम से आ रहा है सर, डॉक्टर कमल किशोर के नाम से नहीं आ रहा सर।
कोई बात नहीं।
सर वो ठीक कर लीजिए सर, अगर हो सकता है तो।
फिर भी मैं कमल ही रहूंगा।
नहीं नहीं, वो सर थोड़ा सा वो ऑडियंस में रहता है वो नाम ना, थोड़ा सा अगर हो सकता है तो सर प्लीज रीनेम कर लीजिए सर।
तो कैसे होगा यार, मुझे पता नहीं है।
सर आप उसी पे। हाँ हो गया सर, हो गया हो गया हो गया। हो गया ठीक।
हो गया।
हो गया सर,
नहीं
हो गया।
गगन बैकएंड से कर दिया, बैकएंड से कर
अच्छा
दिया।
बैकएंड से कर दी, ठीक है सर, ठीक ठीक है।
सर गुड इवनिंग, माय नेम इज विवेक सर. So sir, should we wait for 5 more minutes? Exact timing 7:30. So we'll wait for another delegates also and start at exact 7:30 sir.
ओके ओके।
Okay sir, okay sir.
गुड इवनिंग डॉक्टर बवेजा। आप इसको देख, इसको मैंने बंद करना है, अपनी आवाज को कैसे बंद करूं? कहीं से
Yeah, hello, Dr. Kamal. Hello.
Yes, yes, yes.
Yeah, sir, good evening. So should we start, sir? It is exactly 7:30.
Okay, okay, okay.
Only I think 1 to 2 doctors are there who would be joining in another few minutes. So we'll not waste the time and we'll start the meeting, sir. So with your permission, should I set the context of the meeting, sir?
Please, please, please go.
Oh, okay. Uh, Sir, Gagan is asking if we can wait for another 2 minutes. I think another doctors are joining in next 2 minutes.
Yeah, हाँ प्लीज यार आप अपने हिसाब से स्टार्ट कर लीजिए मुझे बता दीजिए
ठीक है सर तो वी कैन वेट फॉर अनदर 2 minutes at exactly 7:32 or 33. I'll set the contest and we'll start the meeting, sir.
Yes.
Okay, sir. Thank you. Hello.
Hello.
Yeah. So, sir, we'll start now, sir.
Okay.
Yeah. So, I'll just wait for Dr. Anuj has to join. So he'll join in the meantime, sir. So good evening, everyone. My name is Vivek Sharma. I welcome you all on behalf of CIPLA. Thank you, everyone, for joining the session. CIPLA has initiated this forum, which is basically strengthening heart expert forum. And dear doctor, we are delighted to invite you for strengthening heart expert summit on MRA in heart failure. Jump on the bandwagon with today's moderator, Dr. Kamal Kishore, who is GM Cardiology Gold Medalist and ICMR awardee at Rama Advanced Heart and Vascular Research Center, Karnal. If I can give a brief introduction about Dr. Kamal also, before that, we have created this platform to percolate the awareness among all the healthcare professionals regarding the use of aldosterone and in heart failure cascade. All guidelines recommend the use of MRA early along with the ACE or ARB, beta blocker and diuretic. Still in India, MRA is underutilized with only 40 to 60% of patients are on MRA. And I would thank you, Dr. Kamal, who has got this ICMR award in the year 2000. where he's the gold medalist from Rajasthan. He has got this gold medal from Rajasthan in Indian Society of Cardiology. He has published various around about 60 national and international research publication. So thank you, Dr. Kamal, for joining this session and moderating the session. Whereas Dr. Rohit Kurana, Dr. Ashok Bavecha, Dr. Manoj Agarwal, Dr. Praveen Gupta, Dr. Kamal Charaha, Dr. Amit Verma, Dr. Anuj Khamoj, and Dr. Girish Bansal, all the delegates are present over here. Thank you for your participation, sir. I would request each and every delegate present over here to put their video on so that I can have to click some photos and for their active participation. So over to you, sir. You can start your presentation, sir. Over to Dr. Kamal. Sir, over to you.
Yes, Dr. Baveja, please.
Sir, presentation, I think Gagan has shared the presentation. If you ask Gagan, he can change the slide, sir.
Yes, yes. Gagan, can you please change this?
Gagan, can you come on to the first slide? Yes, sir. Over to you, sir.
Next. Gagan, just wait for a minute. मैं अपनी slide खोलता हूँ. Just wait for a minute. Okay, Gagan, आप भी please continue करना. Gagan, am I audible?
Yes, sir. You are audible, sir. You are audible, sir.
Okay. So, a very good evening to all, especially Dr. Kamal Charaya and Dr. Amit Verma. Hi, Amit, क्या?
Good evening, sir.
Good evening. It's a long time to see you. बहुत अच्छा लगा मिलके. और
Yes, sir.
so today we are discussing and I thank Sipla for giving this opportunity. So today agenda is to gain insights on MRA's placement and utilization in heart failure management. Second is hyperkalemia. Most of the doctors who are very much concerned about the hyperkalemia related to the MRA's use, and especially in the renal patient, especially with creatinine on the higher side, which is very common in heart failure populations. And third, the focus will be to create awareness among physicians on MRAs. Next, please. So globally, as we all know, the heart failure burden is quite high. As per the current data, the 26 million people worldwide are suffering from heart failure. So by and large, if I have to say, the cardiac diseases can be divided into two parts only. One is arrhythmia and second is heart failure. There is no third cardiac condition. So any structural heart disease related to ischemia, related to they ultimately are classified in the heart failure populations. So 1 to 2% of the adult population, they are in the developed countries, and the prevalence increases with the age, which is rising to more than 10% among people who are more than 70 years of the age. Probably this data is not relating to our country, because what we used to see in our daily practice, most of the population, they are in the earning age. to the tune of 40 to 60 years of the populations. 70-year population we are not able to catch in India because of the lack of facility, diagnostic challenges. Most of the patient more than 70 they comes in the end stage refractory heart failure. Next, Kritan. So before moving ahead, we would like to take insight from our respective delegates. Amit, just a question for you: what % of heart failure would approach you in a daily OPD, especially in NYHA 2, 3, and 4, and how many heart failure patients they was undiagnosed in India at early stage?
Yes, sir. Sir, exact percentage is very difficult, but I think around 20 to 25% of patients of heart failure, they present for the first time as a NYHA stage 3 or 4 in the emergency or in the ICU. And most of these patients of heart failure in India are underdiagnosed because they are not aware of their symptoms, that if they have got pedal edema or shortness of breath, they are not aware of that it can be a symptom of cardiac disease. Plus, they have a sedentary lifestyle, so they tolerate the symptoms for a longer time because they have a sedentary lifestyle. So it doesn't interfere with their normal lifestyle. And they also, there are more number of patients are smokers in India, so they attribute this dyspnea and symptoms to smoking habit. That's why they seek the attention, medical attention at a later stage, and many times they are first time diagnosed in the NYHA stage 3 or 4 when they develop the pulmonary edema or acute congestive cardiac failure. So these are the some of the reasons they are underdiagnosed, sir.
Yes. Amit, basically simplify में there are two stages जिस पे हम लैग करते हैं. फर्स्ट चीज जो पेशेंट के प्रोफाइल है, पेशेंट ही अपने सिम्टम्स इग्नोर करता है, वो अवेयर नहीं है उस चीज के लिए. सेकेंडली पेशेंट अवेयर हो जाता है, उसकी इंटेंशन अच्छी है, वो मिलना चाह रहा है, लेकिन उसको जो फिजिशियन का कॉन्टेंट है, जो फिजिशियन का कॉन्टैक्ट है, वो नहीं मिल पाता. वो प्रोबली कंसल्ट इन पेरिफेरल ओपीडी, सी कंसल्ट विलेज आरएमपी, जो इतने कॉम्प्लिकेट नहीं हो पाते कि आप हार्ट फेलियर को अर्ली स्टेज पे डायग्नोज कर पाएं. प्रोबेबली हमारा और आपका एक जैसा ही लेवल रहता है कि पेशेंट आएंगे बट दे अल्टीमेटली दे लैंड अप इन स्टेज 3 और स्टेज 4. सो इस चीज को हमें डेफिनेटली इंडिया में हमें अवेयरनेस करना होगा, उसके बाद ही ये काफी हद तक चीजें इम्प्रूव होगी. सेकंड क्वेश्चन डॉक्टर कमल चराया, फॉर आपका एक्सपीरियंस क्या रहेगा? व्हाट आर द डायग्नोस्टिक एंड प्रोग्नोस्टिक टूल्स used by you for heart failure patients?
Sir, I think.
Please sir.
I think first of all, the history and physical examination, if we go stepwise, that is the most important thing for a diagnostic tool. You have to assess the patient, has blood pressure, pedal edema, look into his chest and auscultate the chest thoroughly, look for any crepitation or basal crepitations. And the most important diagnostic approach, I would say, still stays with the cardiologist, that is the echocardiography, where you assess the ejection fraction, left ventricular ejection fraction of the patient. Anything less than 50% is, I think, you would be the best judge in deciding it later on. And objective evidence of cardiac structural or functional abnormalities which are consistent with the left ventricular diastolic dysfunction, raised LV filling pressures, they are all important factors as far as I feel that the diagnosis for your heart failure is concerned. Though the next stage is the advanced stages of heart failure, where ejection fraction again is around 30%, isolated right ventricular failure could be there, and persistent symptoms of heart failure and NYHA class 3 advanced would be there.
Yeah, thank you, sir. Thank you so much for the nice description. Or so
we can do lab BNP also, sir. Yeah. BNP, yes. Lab level measurement to see the prognostic.
Basically, there are अदर देन इको हमारे पास और बहुत सारे टूल्स हैं जिसकी मदद से हम डायग्नोस कर पाएंगे. डेफिनेटली फर्स्ट जो सबसे इम्पोर्टेंट है वो पेशेंट की हिस्ट्री और क्लिनिकल एग्जामिनेशन. काफ़ी हद तक से पेशेंट इज लैंडिंग टू यू इन अ tachypnic phase, his JVP is raised and he is orthopnic, PDDMA is quite high, BNP markers high. So these are criteria जो एक हमें कंपेल करते हैं कि यस हमें हार्ट फेलियर के एंगल से सोचना चाहिए. So डॉक्टर कमल चराया, आर यू ऑन? हेलो डॉक्टर कमल चराया. ओके. सो प्रोग्नोस्टिक टूल्स के लिए जैसे सर ने बोला कि बीएनपी का भी एक अपना रोल है. बीएनपी हमें डायग्नोसिस में भी हेल्प करता है और साथ में प्रोग्नोसिस के लिए भी इट हैज़ इट्स ओन वैल्यू. एंड डेफिनेटली इको देन इज अ मेजर डिसाइडिंग फैक्टर्स. क्या हमें कैटेगराइज करना है और आगे किस हिसाब से हमें उसका प्लान करना है, वेदर पेशेंट नीड इमीडिएट इमरजेंसी ट्रीटमेंट और एडमिशंस और एनी डिवाइस थेरेपीज. देयर आर सो मेनी थिंग्स. So, Gagan, please, can you move the slides? So, as per 2021 updates, in comparison to last guidelines, the ACC expert consensus decision pathway for optimization of the heart failure therapy, the caution has been given for MRA that should be used with cautions. If the serum potassium concentration is more than 5 millimole per liter, and if there is a severe renal impairment, that is GFR less than 30 ml per minute body scale area, or creatinine more than 2.5 milligram % in men, or more than 2 for the female. Next. So sir, I would like to put a question for you. What are the parameters that you would like to test, or that would you compel you that whether you should start MRAs or not, that create a hesitation for you for optimal use of MRAs? Dr. Agarwal, please, sir. What's your take on these questions?
Sir, if the basal serum potassium level is around 4.5, then if we start MRAs, then we should be vigilant about it, measuring the serum potassium level. Similarly,
Yes, yes.
if there are certain high risk groups, if we are thinking of having worsening renal functions, serum potassium level of 4.5, or the patient is having coexisting renal disease, then one should be vigilant and one should keep on measuring serum potassium level at every 3 weeks period.
Yes, definitely, sir. But actually we have cardiac and renal centers. So a mixed population present to our department. Some have renal disease dominantly, some have cardiac diseases. So even being a cardiologist, the biggest fear for me for prescribing the MRI is the serum potassium level. Because once the serum creatinine is deranged and we are prescribing the MRAs, the biggest concern is whether the patient will come back for serum potassium level measurement or not. This is the one concern that is always in my mind, whether I should accelerate the therapy of MRAs or not. So before prescribing MRAs, one should go for serum potassium and then should titrate accordingly, according to serum potassium and creatinine, the doses of the MRAs. So next, please.
Sir, moreover, I think that the increased risk of adverse events was mostly confined to patients who are having borderline or preserved ejection fraction with MRAs. If the patient is having reduced ejection fraction less than 35%, then chances of having hyperkalemia is very less. But in cases of patients having borderline or preserved ejection fraction, then we should be not starting MRAs, or they have more chances of having hyperkalemia. If you agree with this or not.
So I don't have any logic for these. Do you have any logic for such kind of belief? So you are not audible.
Yeah. Dr. Manoj, you are on mute.
Sir, the literature says that with MRAs, most adverse events are noticed when they are given to the patients having borderline or preserved ejection fraction. So in such patients, we should.
One logic Yes, one logic that may be there, that is because the patient who are on reduced ejection fraction, severe LV dysfunction, they require higher doses of flaccid. So that may compensate the potassium level with the MRAs. So this may be the one.
This could be the same. Yes, sir.
This could be the software, but per se, incidence of potassium hyperkalemia is more related to the serum creatinine level rather than the other factors. So we have to be careful prescribing and escalating the dose of MRAs in the heart failure patients, and specifically look for the potassium level at the baseline and on the follow-up for rise of the potassium level. So as per the guideline recommended, it is for heart failure reduced ejection fraction, MRA is recommended to reduce the risk of heart failure hospitalizations and death. So I think everybody knows about the heart failure mid-range ejection fraction. Amit?
Yes, sir.
Amit, yeah. I think you must be aware of this heart failure mid-range ejection fraction.
The classification of heart failure based on ejection fraction.
Yes.
Yes, sir. If it is less than 50%, sometimes you classify in 3 categories: less than 30%, 30 to 50, and above 50. More than 50% is heart failure with preserved ejection fraction, and 40 to 50 is intermediate, and less than 40 is low ejection fraction, heart failure with low ejection fraction.
There is a new definition that has been incorporated, that is heart failure mid ejection fractions. So most of these population is that category of patient where it is somewhat dilemma about the exact classification of the heart failure. And second category is that group of the patient which earlier they were on the heart failure reduced ejection fraction, but they now have improved ejection fractions because of the optimal drugs, optimal uses of drugs, including beta blocker, ARNI, and current novel therapy. So their ejection fraction is say 40 to 50%, and now there was always confusion. What should we label? Should we label it now heart failure preserved ejection fraction or heart failure reduced ejection fractions? So there is a approved term that is heart failure mid-range ejection fraction. So Gagan, please can you move on slides? Yes, the management of heart failure has changed a lot from in the last decades. So initially we were having only 2 drugs, that is diuretics initially were there, but that was only for reduced hospitalization. There was no mortality benefits. Then after the theory of RAS and sympathetic activation, then there was proven role of the beta blocker and AS or ARNI comes. And now very recently there is a new addition, that is SGLT2 inhibitors also, that is DAPA, AMPA, this category of drugs, because CVOT trials based on this molecule that has clearly shown the all-cause mortality benefit in the heart failure patients. And fourth one is the MRAs. The main trial that lead to incorporation of the MRAs was RAILS trials based on the something like 2,000 patients, and they ultimately shows approximately 30 to 35% of the mortality benefit, all-cause mortality benefit, both for the pump failure as well as the rhythm sudden cardiac death benefits. So MRA has a class 1 indication for heart failure reduced ejection fractions. And now the question is when we should start the MRAs. So before putting a opening the debate when we should start, I would like to just to focus on the pathophysiology of this acute decompensation. So acute decompensation happens because of sympathetic overactivations. So once there is sympathetic overactivations, there is activation of RAS and ultimately increase in the angiotensin levels, then receptor activations, and there is a stage of hyperaldosteronism that is ultimately lead to the fibrosis, and all these cascades get started. So because use of MRAs, because sympathetic systems, they have the earliest compensatory mechanism that start with the acute decompensations. So to match this height of the sympathetic nervous systems, theoretically, MRA should also be started as the earliest, as early possible as possible for the heart failure decompensation stages. So as we start, the earlier we start the MRAs, the more we cut down the risk of mortality because of pump failure arrhythmic events to our patients. So we must match this use of MRA, early use of MRA, with the theoretical explanation that yes, it is working on a sympathetic nervous system activations. The next, please. So, sir, and if you would like to, Amit, what percent of patients do you use MRAs for heart failure management? Now I am adding one more question to it. And after how many days you like to start MRAs?
Sir, my most of the patients are on the combination of diuretic and MRA, like dietroplas and this form. And it is started during the admission time as early as possible. Only if the patient has got the renal failure or hyperkalemia or other contraindication to the drugs, then I don't start MRA. Otherwise, the combination of spironolactone and this diuretic and MRA is initiated as early as possible in all the patients, except renal failure patients.
हम बीटा ब्लॉकर को पहले प्रेफरेंस देंगे या एमआरएस या एएस, मतलब इन तीनों मॉलिक्यूल्स जैसे all has all cause mortalities and all has they should start as early as possible. So if हमें कुछ दो चूज करना हो तो हम किस पे ज्यादा बैट करेंगे?
First of all, sir, we start the symptomatic treatment with diuretics, and after that we add ACE inhibitors, and after the stabilization of hemodynamics, then I add beta blockers and MRAs, both.
Yes, very right, very right. I think Dr. Praveen is also with us. Good evening, Dr. Praveen.
Sir, which diuretic will you prefer, loop diuretic or thiazide diuretic with this spironolactone?
Sir, you are not audible. Dr. Kamal, sir, you are not audible.
Sir, I think they have been logged out. I'll just make a phone. Gagan, if you can make a phone call to Dr. Kamal, I think they have been logged out due to some network issue or I don't know. Gagan, if you can make a phone call.
सर का कॉल आया, वो उनकी एक बैटरी खत्म हो गई, कह रहे 2 मिनट में ज्वाइन कर रहा हूँ बैक। हेलो विवेक सर, हेलो।
ठीक है ठीक है ठीक है,
2 मिनट में ज्वाइन कर रहे हैं, कह रहे मेरी गलती बैटरी।
ओके।
Hello, Gagan?
Yes, sir. Yes, sir. Now you are audible and visible, sir.
Sorry, yeah, actually, there was some power issue.
Okay, okay, sir. Yeah, please continue, sir.
So, Amita, Amit?
Yes, sir. Yes.
Okay, okay.
Sir, Dr. Manoj was asking something and you have been disconnected. Sir, over to you, Dr. Manoj, please, sir.
Please, sir.
Sir, which diuretics one should prefer? Loop over thiazide or over which one group of this diuretic? Loop diuretics or thiazide diuretics?
For initially decompensated, loop diuretics are preferred choice because they are more intense. The thiazide drugs, they are low dose diuretics. They keep on things, but the effect is not so much intense in the early acute decompensation stage. But then if you have put a finger on loop diuretics, I would like to add one more thing. Once we are using the loop diuretics, so what actually is happening, it definitely leads to more and more of a free urine output is get increased, patient release of the congestive symptoms, but at the same time it is activating the RAS system again and again, because
Again and again.
yes, macula
Yes.
densa is getting inhibited, and it is setting a stage of secondary hyperaldosteronism. So, considering this issue, because loop diuretics increases the secondary aldosteronism, so there was a one more trial, that is Athena heart failure trial, that was focused on currently on this on only this issue, that on the higher dose of MRAs, that is a spironolactone of 100 milligram per day, probably that will cut down the effect of the secondary hyper aldosteronisms, that was induced by the loop diuretics. That is probably that was having some favorable effect, but then at the cost of more hyperkalemia and the renal issues. So loop diuretics are definitely drug of choice for the initial decompensated stage. Now there are two ways we can give the loop diuretics. First is the intermittent, and second is the continuous dosage. In our setup, we use the continuous infusion therapies. That is more reliable because secondary sodium retention is very less in that kind of the therapy. So one may opt for the intermittent dosing, that is 20 milligrams 6 hourly, 8 hourly, depending on the symptoms, or the infusion dose depending upon the daily maximum dosage of the loop diuretics.
So at what rate you give the infusion, sir, of this
If the patient
loop
is
diuretic?
if the patient is very dyspneic, very sick, then we can go for directly for the 10 milligram per hour.
10 milligram per hour.
Yeah.
Okay.
If the BP, if there is some issue related to the blood pressures, or we also want to add the beta blocker or ACE inhibitors, then we cut down the loop diuretics. Then we start at the 5 milligram per hour.
Okay.
Yes.
And then where do you place this metalazone if the patient is not responding?
Metazolone is used only in the current setting. Metazolone is used only when we are facing that we are not able to attain that urine output even
With
the
loop
high dose
diuretics.
of the loop diuretics. Then we go for
Yes.
the sequential diuresis. That is, first we give the loop diuretics, and after 30 to 40 minutes we give the challenge of this metazolone 2.5 or 5 milligram. So if the
Yes, sir. Thank you.
please, sir. Okay.
Thank you, sir.
Okay. Yeah, Gagan, can you just move on the slide? So already we have discussed this aldosterone escape. That is, once we are using the use of MRAs as early as possible on the top of heart failure treatment, preferably at the discharge after an episode of decompensate heart failure. So once the patient get admitted in our ICU, that is the opportunity to start all the molecular at the low doses, and then keep on down titrate the molecule which does not give us the mortality benefit, like keep the doses of loop diuretics and the minimal level, and start building up the doses of AS inhibitors, ARB or ARB inhibitors, or ARNI or beta blocker, which gives us the maximum mortality benefits. So the progressive escape of aldosterone, as we have already discussed, that lead to the contribute to the ACE1 resistance. That is the same phenomena that we have discussed, that is the secondary hyperaldosteronism. So Gagan, can you please just move on the slide? Gagan, next slide. Next slide.
Gagan. Yes.
So comes to the clinical scenario. Where do you prefer? Dr. Parveen Gupta, are you there? Dr. Parveen? Dr. Kamal Kishore? I think both are not. Amit, are you there?
Yes, sir. Yes, sir.
Amit, अच्छा let's discuss. आप एप्ली और स्पाइरोलेक्टोन्स का क्या आपका एक्सपीरियंस है? कब आप ज़्यादा प्रेफर एप्ली करते हो, कब आप ज़्यादा प्रेफर स्पाइरोलेक्टोन करते हो?
Yes, sir. Sir, Eplerenone is costlier as compared to Aldactone. So I use it as a second line agent when patient develops side effects of spironolactone like gynecomastia. In such patients, I use Eplerenone. And also if patient is affording, then we can straight away start with the Eplerenone.
Okay, great. So trials also, they have their own data also. Amit, you must be aware, there are major two trials. The Rails trials was on the spironolactone and Ephesus was on the Apli. Rails trial has shown the 33 to 33, I think 35% of the mortality benefit, and that was all cause mortality. That was related to both the pump failure death as well as a sudden cardiac death.
Yes,
but Ephesus trials has only 16 to 17% of the mortality benefit. So
yes, sir.
Spironolactone is definitely drug of choice as of now, and but the thing is that should be started on the earliest possible days of the hospitalization.
Yes, sir.
Gagan, next. So the dose adjustment that already Dr. Purana has already we have discussed that if the potassium is less than 4, then increase the dose. If spironolactone is 25 milligram per day, then increase to the 50 milligram per day. And if initial MRA dose was 25 milligram every other day, then increase to on the daily doses. If the potassium is more than 6, then stop the MRA treatment, reassess potassium level after 1 week, and potassium level, whenever the potassium level comes less than 6, initiate the potassium binding and reintroduce the MRAs. So same stories with the Apli, we have to down titrate when the potassium is the higher side, and we have to up titrate when the potassium is in the normal. Go to next. So, Dr. Parveen, are you audible? I think Parveen is busy with the OPD. Dr. Purana, Dr. Agarwal? Yes, sir. Sir, for you, what is your preferred doses of spironolactone for initial, and for how many doses you go for the maximum?
Well, it depends upon the symptoms of the patients. We start with about 50 milligram of spironolactone, and with along with 10 milligram of diuretics, and we increase accordingly, measuring the potassium level and the symptoms of the patients only. And effective dose is only 100 milligram per day for spironolactone.
Okay. I think loop diuretics and
spironolactone combinations.
That is a better option rather than thiazide in heart failure stage.
Only in the cases of ascites, where aldosterone levels are very high, there we prefer only aldactone, only spironolactone.
Yes. But for congestive failure, loop diuretics are drug of choice. And patient should be weaned off the loop diuretics as soon as possible, so that we can get a chance to build the doses of beta blocker or ACE inhibitors. Okay, next. So what percent of heart failure patients on MRA develop hyperkalemia? So अमित, आपका क्या एक्सपीरियंस है अपनी ओपीडी में? कितना परसेंट पेशेंट को हमें डाउन टाइट्रेट करना पड़ता है, या आपको लगता है कि यार ये चैलेंजिंग हो गया है हमारे इसको, या बंद ही कर दूं मैं इसको, छोड़ देता हूं?
Generally, I use lower dose, sir, as a combination with the loop diuretic, like 25 milligram normally. So at this dose, the incidence is not very high.
Yes.
And it depends on the renal function of the patient. Generally, around 10 to 20% of patients are there. In those patients, I had to discontinue the treatment. Otherwise, 25 milligram they tolerate very well.
Yes, yes. Dr. Khurana, sir, are you busy? Dr. Khurana, are you busy, sir? Okay.
Sir, Dr. Baveja is there. I think Dr. Khurana is
Sir,
busy.
sir, what's your take on this thing that on how many patients do you have challenges in initiating or escalating the dose of MRAs?
Sir, I am not able to listen to.
So I am repeating my question, sir. In how many percentage of heart failure patients do you face challenge related to potassium level or hyperkalemia level that yes, I should de-escalate the dose of MRAs or I should stop the dose of MRAs because it is creating the potassium disturbance in my patient?
Sir, if there is a significant renal impairment as well as there is a significant rise in the potassium level, we must stop it. We normally stop it after 5.5 and 6 milligrams.
Okay, great, sir, great. Gagan, next, please. Next, we have already discussed the FSS style. So this is a wonderful slide that we must consider. The earlier administration of the Eplerenone, that is 3 to 7 days. See, the basis of this slide is very clear. The same slide is true for ACE and ARB inhibitors also. Once there is acute decompensations, the first system that get activated is the sympathetic nervous system activations. So all the ACE levels are it's in the peak during the initially 24 to 48 hours. Aldosterone is at the peak in the initial 24 to 48 hours. So early we start the beta blocker and aldo MRAs. The better is the results and maximum we gain on the form of the mortality benefits. So this is the KM curve that is suggesting if we start the MRA, that is MRAs early, that is the uppermost dark black line, we get the maximum survival if we start the early, that is within 7 days, as compared to the populations in which we start the APLI in the later phase. So the survival curve at the end of 2 years, that is quite significantly higher in case of the populations where the APLI was started within 7 days. So early we start the APLI or aldosterones, the higher is the survival benefit or mortality benefit in the long duration of the heart failure journey. Okay, next. So in clinical practice, how early are MRAs initiated for that? I think I have already discussed with the Amit. Yes, we plan to start the MRAs right at the discharge, just before the discharge of the patient, and we try to down titrate the loop diuretics as soon as possible and up titrate the beta blocker or MRAs or ACE inhibitor as soon as possible on the follow-up visits. Next, Gagan. Gagan, next, please. Gagan. Yes, this is a therapeutic algorithm for the class 1 therapy for a patient with a heart failure, reduced ejection fraction. So the loop diuretics is they do not have any mortality benefit. They are used only for the freeze retentions. So just be focused on that. Most of the physician that live with me, that they start complaining that yes, sir, we are not able to build the maximum dose of beta blocker or ARNI or MRA, especially debate was on the ARNI where the hypertension is a side effect. So the key point is start the loop diuretics early, dry your patients, estimate the dose of loop diuretic as early as possible, and start building the ACE inhibitors, beta blocker, and MRAs. Try to plan out, introduce every therapy during hospital stay, and keep up titrating the therapy on the follow-up visits. So after initiating the therapies, if the EF is less than 30%,
मेरा ये सुन ही नहीं रहा मुझे.
am I audible?
नहीं.
Yes, sir. You are audible, sir.
Okay.
Yes, sir. Yes, sir.
So if QRS is nice and it is less than 130 millisecond, then go for ICD. And if it is more than 34, medical management optimal uses. If patient is having QRS duration more than 130, go for the device therapy in the form of CRT or DOT, whatever is being recommended as per guidelines. Gagan, next. So now the question is, at what stage of heart failure diuretics and MRIs both are needed? I think we have discussed already a lot during initial phase when we try to dry up the patients. Initially introduce the diuretic at the higher dose and down titrate the patient, keep the diuretics away as soon as possible so that we build up the maximum doses of beta blocker and other mortality benefit therapies. So what is preferred choice of therapies? Dr. Kamal Chalaya, are you on? Dr. Kamal?
But you are not audible properly, please. Please speak loudly.
Okay. Sir, what is the preferred choice of the therapy for you?
Sir, Dr. Praveen is there, sir. He is asking, I think, sir.
Okay. Dr. Praveen?
यार आवाज ही नहीं आ रही मुझे तो.
Dr. Praveen, you are audible. Can you please continue?
Yeah. Hello, Dr. Praveen. We can hear you, sir.
Okay. Dr. Rohit, sir. Dr. Rohit, sir. Sir, what's your take on this question? What is the preferred choice of therapy for you? What Eplenon, Eple plus torso, spironolactone, or spinalo plus torso?
Sir, cost effectiveness has also to be kept in mind. Eplenon is very expensive and everybody cannot afford it. Otherwise, definitely this would be the drug of choice with torsemide, of course. But in such cases, one can start with spironolactone, maybe start with 50 milligrams plus torsemide. This is my take. Rest, the house can decide.
Okay. Dr. Ashok, what's your take on this question?
I agree with Dr. Praveen that in current setting, if we are given a choice, if there is no price constraint, we can definitely go for eplerenone plus torsemide. But due to the price constraint, we are using this spironolactone and torsemide.
Okay. Amit, what's your take on this question?
Sir, D, because mortality benefit of spironolactone is higher.
Yes. Definitely, sir. To Dr. Rohit and Dr. Ashok, sir, I would like to add one more thought for you that depending upon the trial, definitely spironolactone has an edge over the eplerenone. Eplerenone we generally use whenever there is a side effect related to the spironolactones. Otherwise, the majority of the trials, that is rails trials, that have shown a very clear benefit or mortality benefit. Gagan, next slide, please. Gagan, next slide.
Other than heart failure, we are using these MRIs in cases of cirrhosis with plus even in resistant hypertension, we are using it.
Definitely. These are the two indications. Especially in the resistance hypertension, we give a challenge of these MRAs.
Sir, is there any role in hypokalemic paralysis? Recurrent hypokalemic paralysis. Is there role of aldactone in such patients?
Amit?
Yes, sir.
Okay. मुझे नहीं पता है. Probably Dr. Praveen, the question is for you. Dr. Praveen?
Yes, sir.
Dr. Amit, एक बार please repeat करो questions.
Sir, is there any role of aldactone in patients of recurrent hypokalemic periodic paralysis?
In patients of hypokalemic periodic paralysis, actually, I have never heard or I have never used. Actually, this condition is actually very rare. Maybe we are seeing only one patient in per year. So I have never tried even this. The only place I have tried Ejection apart from heart failure is resistant hypertension and chronic liver disease. So these are the two disease conditions where I have used Ejection other than these conditions. Otherwise, hypokalemic periodic paralysis I have never used. I just
Sir, there is no role of spironolactone in hypokalemic periodic paralysis. I think so, because spironolactone is effective only when the aldosterone levels are very high.
exactly.
Otherwise, there is no effect of spironolactone.
Because
In all these
the
cases,
pathophysiology of hypokalemic periodic paralysis, I think spironolactone will not act on that pathway. So
there
it will be
is
of
not an increased level of aldosterone.
exactly, that will be of no use.
There will be no use. So only in these cases, as you have said, resistant hypertension, or we can use in the cases of cirrhosis liver where the aldosterone level is very high. Then
Exactly.
it can be used as a natriuretic hormone, or to reduce proteinuria in diabetic kidney patients also. Then they definitely effect in reducing the protein.
Yes, sir. Thank you, sir.
Last question.
I have got one question. Over the since its inception in 1950s, after that the spironolactone initially was discovered for this hypertension only, but later on, because of the end organ protection and different chronic renal disease, now it has been incorporated into treatment of the heart failure plus cirrhosis liver as well as this resistant hypertension only. One thing I would like to listen from the audience, how many patients we get by as a steroid induced hypertension?
Dr. Parveen, आप म्यूट पे हैं.
Role in steroid induced hypertension for Ejection.
Yes, sir.
Spironolactone, as such, specifically Ejection to be used in steroid induced hypertension, I don't think, sir. I have never used for such an indication.
I just want to know the steroid because of other indications. Patients who are on patients of rheumatoid arthritis taking steroid for a longer period for the last many years.
They are taking steroids and they develop hypertension. So
and then they develop hypertension in these cases. Can it be a drug of choice or?
No, sir. In these patients, I think I am using ACE inhibitors ARB group. So why MRA should be using these patients? I don't know, because steroid will obviously, actually steroid itself has a potassium raising tendency. So using a Ejection simultaneously with steroid, maybe we are making patient more prone to hyperkalemia. So I don't think this should be a drug of choice at least.
Thank you.
Gagan, I think it's over now, and I would like to thank all the delegates and especially senior member Dr. Rohit and Dr. Ashok, Dr. Parveen, Dr. Amit for this wonderful debate and active involvement of this meeting. And I would like to thank Cipla by Heart that they have organized the meet and they have updated. They have given us chance to get updated regarding a molecule which is generally ignored, being discussed as an individual entity for heart failure, though it has a very active and vital role in reducing the mortality for the heart failure patients. Thank you, everybody. Thank you, Amit.
Thank you.
Thank you, sir, for a very informative talk.
So thank you on behalf of Cipla, sir. I would thank each and every delegate present over here for their active participation and Dr. Kamal for organizing and moderating this session, as well as Dr. Praveen and Dr. Baveja, Dr. Khurana, Dr. Amit, Dr. Bansal, everyone who has joined over here and their participation and their time from their busy schedule, despite of their OPDs and evening patients also you are looking after, despite you have taken out the time in the daily, despite of a weekend. It is not a weekend, but you have taken the time in the mid of the. So thank you, sir, Good evening in the end, sir. Thank you. Stay safe, stay healthy, sir.
Thank you.
Thank you, sir.